Hi, my name is Edward Heffler. I'm presenting a case study about an insulin overdose for my class HCA 719 at UNLV. So as an overview, there was a senior anesthesia resident who'd been working nonstop from 6:30 a.m. to 3 a.m. the next day and had recently gotten out of a surgery. And that resident gets a page for an emergency surgery for a patient in the cardiac intensive care unit. The patient was a 78-year-old male with an active myocardial infarction, and there was fear of ischemic bowel disease. The patient was already on pressors and intubated, and the kidney function was worsening, but his vital signs were stable. The anesthesiology attending and the anesthesia team were assembled to get ready to bring this patient into the operating room. So, in the operating room, shortly after surgery starts, the diagnosis of ischemic bowel disease is confirmed. Um, the surgery team goes ahead and starts removing the area of ischemic bowel. The patient ends up needing a red blood cell transfusion. His renal function is worsening and his potassium is high. All these together create several problems. One, red blood cell transfusion can often bring up potassium. Number two, your kidneys are what helps bring and take extra potassium out of your body. And if the potassium goes too high, it can cause various arrhythmias inside the heart. And that's the last thing you want on a patient that's already suffering from myocardial infarction that's in the middle of an operation. So the attending tells the anesthesia resident to administer 10 units of insulin and other medications for the high potassium, which would be calcium and glucose. And what they're trying to do is they're trying to drive the potassium into the cells. You want to drive it into the cells for now, and then later on you can try and get the potassium out of the body. But short term, this will help the potassium get low enough where the heart is still stable. So the resident gets 10 cc's of insulin and injects it, and right after he does it, he realizes he injected concentrated insulin of 100 units per cc, or a total of 1,000 units of insulin. So now the event response. So the resident realizes what he did right away, and he notifies the anesthesia attending what happened. The patient gets IV dextrose. The surgery is finished, and the patient is brought back to the cardiac intensive care unit. The resident goes with the anesthesia attending to speak to the family. They tell them what occurred. They let them know that they're going to be monitoring the patient's glucose, and they're going to do everything they can for the patient. The patient's glucose is monitored vigilantly, and the glucose never gets dangerously low at any time. However, the patient expires later that day anyways. The resident blames themselves. They have a brief conversation with the anesthesia attending, and they go home, and they're in one of these situations where they feel like everything's kind of their fault. That maybe this patient might have lived if they didn't put their body under that extra stress from having all that insulin. So what are the problems? So there's a few problems here. One is the insulin came up concentrated with 100 units per milliliter. Two, you had a fatigued resident was put in charge of administering medications. And three, there was nothing that's set up to help the second victim. If you're not familiar with the term second victim is a term that's used in healthcare. And when a patient suffers any kind of severe injury or possible death, it's not uncommon that doctors, nurses, nursing assistants, and other medical staff might blame themselves for what occurred to the patient, and sometimes this could have a very negative effect. And so we refer to that as the second victim. In this case, there was nothing set up, at least nothing acutely, for that anesthesia resident. So we have to think about our goals of improvement for this case. So what are our goals? One, we want to prevent similar situations where the patient has administered too much insulin from happening again. Number two, we want this to occur not just in the OR, but the entire hospital, if there's any other places where the insulin is concentrated. Three, we want to make sure the second victims get the help they need early on. It's important to not let those negative feelings fester. So we need to do what we call a root cause analysis. So looking at the current processes, the ones regarding insulin, so it's sent to the OR with 100 units per cc. Must be diluted with 99 cc's of normal saline to have 1 unit per cc. And then it needs to be labeled to prevent reuse errors, especially if you need to give insulin multiple times during some longer surgeries. Our fatigue process, well, the residents work up to 24 hours straight. The anesthesia team was assembled. In this case, there doesn't seem to have been any kind of designation on who should be giving them medications based on fatigue levels. It's just that this was the senior resident on call, and they were just getting hit with surgery after surgery, and they just went into the next one. This was a very serious emergency surgery. And then finally, the second victims. As I mentioned earlier, there was no early attempt to reach out to the second victim. The resident left blaming themselves for the death of the patient. I created what we call a fishbone diagram, where we try and look at the things that feed into the end result. In this case, the end result here is the patient received too much insulin. So looking at the policies, the equipment, the people, and the environment that feed into it. First the people, you had the anesthesia resident themselves, who was the main person inside the study. You had the patient who passed away, the anesthesia attending, the surgical team, and all the other OR staff. For equipment, I just kept it a little basic here at this point. There's a vitals monitoring machine, the respirator, just about every patient in the OR is intubated. And then finally the medications, some are concentrated and not ready to use, including the insulin inside the OR, at least in this case the insulin. Then looking at the environment. So you had a critically ill patient even before the surgery started. You have higher stress normally in emergency surgeries. The resident themselves was fatigued, and part of that environment for fatigue is, is there any encouragement to speaking up if you feel a little fatigued, or is there a concern maybe that you'll be seen as being weak, or something like that if you speak up and say, hey, I'm a little tired. And so that's all part of the environment. And then finally our policies. So what are our policies on operating room medications? Is there no acute intervention for the second victims? What are the emergency surgery policies, and what are the policies on fatigue? So all of these things kind of go together, and they feed into the patient receiving too much insulin. So it wasn't just, one person made a mistake that led to this. It was a lot of things all going on all at the same time that we're looking at to say, hey, how could we prevent this from happening again? Because if we don't do anything, it's just a matter of time for something like this does happen again. And some important questions, we came up with here is, are we giving staff regular training and feedback on fatigue and second victims? These are important issues. So this has to do with the residents, the OR staff, the anesthesia attendings. This has to do with, the policies on, acute interventions for second victims, policies on fatigue. This actually has to do with the fatigue environment. Are people being encouraged to go into the operating room when they're fatigued? Are they being encouraged to speak up when they're too fatigued? Another question, which I guess brought up, I just said, do we encourage staff to speak up when they're fatigued? It's not uncommon in certain, areas of medicine that, maybe they're not encouraged to speak up. And that may have been something that was done in the old days where, you had to gut it out. There were no 24-hour limits to residents before. There's currently an 80-hour work week limit for the residents. These things all weren't around, and there's still some of that atmosphere around where people feel like they just need to show they can tough it out. And we need to make sure that patients not only, or rather residents can not only sense when they're fatigued, but that they're willing to speak up about it. A couple other questions, should all our OR medications be in ready-to-use concentrations? Is there any reason why any of our medications are coming concentrated in the OR and need to be changed? And in that respect, if they need to come into the OR concentrated, are they appropriately marked? Should attendings try to determine which residents are more likely to be fatigued before procedures, especially emergency procedures in the middle of the night? And we could see all the things that lead into that. And then finally, do we need to set up better acute and follow-up interventions for second victims? This goes back to our policies. This goes into our environment, and this goes into the people involved. In this case, it was a resident, but it's not uncommon. Our second victims are attendings, nurses, and as I mentioned, other hospital staff. So implementing improvement plans. So how many OR medications need to be diluted, and is there a warning label for any of them? So this is an important question we need to get answered, and we need to do this with the anesthesiologist and with the pharmacy. Now, insulin is never used at 100 cc's anywhere in the hospital. It's not used that way subcutaneously. It's not used IV. And there could be other high-stress places, not just the OR, in the various intensive care units, rapid response teams. So, this is something where it's concentrated to the point where it's not being used at. What can we do to prevent this from happening? And so, are we saving money with buying these medications concentrated? So, how do we know? So one of the things we can look at is the cost of self-diluting versus buying diluted medications. So if we buy the concentrated medications, let's say we dilute them in the OR, we can look at how much time is spent, what's our cost of labor, what's our cost on that sterile normal saline in the containers. They have to be sterile because anything you're injecting in a patient has to be sterile. So what's our real cost? Are we really saving anything? So that's something important to look at. And finally, how about a unique sticker for any medication that needs to be non-diluted when it goes to the OR or anywhere else? So let's say maybe there's no medications that have labels that have like orange and purple stripes. As soon as those medications get unpacked inside the pharmacy, you can put an orange and purple sticker on them, and that would signify to everyone that this is a concentrated medication that needs to be diluted before being used. Other improvement plan areas, so regular training to recognize fatigue in yourself and others. Sometimes we don't always realize when we get fatigued, and it's important to recognize it in others too, so you can mention it to them. We want to create an atmosphere where the residents do not fear admitting when they are fatigued, that it's okay to speak up and let someone else do it. Finally, we consider having the attending try and determine who is least fatigued for late night emergency surgeries or procedures. And this wouldn't just be for anesthesia, this could be for surgery, this could be for maybe an endoscopic procedure from another specialty. So this should kind of apply to all the residents of all the departments. And then finally, implementing our improvement plans regarding the second victims. So we could assign everyone the IHI training for adverse events to staff. People do receive CME credits for that. It's important we identify second victims and have human resource specialists reach out to them early for interventions to see how they're doing. Depression, sadness, difficulty concentrating, intrusive memories, sleep disturbances, and suicide as a worst result have all come from second victims. And not just residents, but all doctors, nurses, CNAs are affected by this. And it's important to have follow-up with the second victim, not just the initial contact, to make sure that they're doing okay and they continue to do well. So these are all plans to implement to improve on everything that was done to not only help prevent these events from happening again, but to also help prevent any suffering that the second victims have.